Welcome to DHR Health Talks, the official podcast of DHR Health, where we open the mic to our physicians, specialists, and healthcare leaders to discuss the latest in medicine, wellness, innovation, and everything in between. I'm your host, Dr. Dan Guerra. In honor of Breast Cancer Awareness Month, we will be discussing the importance of early detection, advances in treatment, and how our team at DHR Health is supporting patients every step of the way. Joining us in this conversation is Dr. Lisa Chapa, who serves as a breast surgical oncologist at DHR Health. Welcome, Dr. Chapa. Thank you for joining us on our podcast. So before we start, we know that you went to medical school at Texas A&M.
Right.
And you did your residency at Baylor Scott & White Hospital in Temple.
That's right.
And then you did a fellowship in breast surgical oncology at Mount Sinai Hospital in New York City.
Yes.
Is there anything more you'd like to add about your background or about the care that you give here at DHR Health?
Sure. I think it's really important to talk about where I trained, but it's also important to talk about where I'm from. And I'm a Valley native. This is my hometown. I grew up in McAllen. I attended McAllen Public Schools. And so much of my motivation for coming back and practicing in the Valley was really just giving back to the community that raised me. I feel like I'm really suited to this community. It's the community I grew up in, but I'm also bilingual. And so I think I fit a specific niche and need, and I'm really proud to be back home.
Good. So we know that you did a fellowship. What tools does a fellowship provide you in breast surgical oncology above and beyond general surgery?
That's a great question. So in a general surgery residency, we are learning to operate on the entire body, and we learn to do all cancers. In a fellowship, not the entire year is focused on the surgical aspects of breast cancer treatment, because the 5 years preceding in general surgery, that's when we learn to be surgeons. We go into fellowship knowing how to do the breast surgeries. But what's unique about doing a fellowship is that breast cancer care is now very multidisciplinary, meaning that patients aren't just having surgery to treat their breast cancer. They're also maybe receiving radiation or chemotherapy. And so it's really important for an oncologist, a surgical oncologist like myself, to understand the full spectrum of treatments, because there are times when a patient does need surgery, but surgery should not come first. Chemotherapy should come first. So in a fellowship, we spend about 6 months of the fellowship doing surgery, but the other 6 months are spent rotating with medical oncology, radiation oncology, pathology, radiology. We spend some time on the palliative care service team. And so that gives us a very comprehensive view of breast cancer treatment and lets us be not just a surgeon to the patient, but a true oncologist.
With the care that you provide here at DHR Health, is it only breast cancer surgery that you're doing?
That's a good question. So I do mostly breast cancer surgery, but I also do all surgeries of the breast. So while I am a breast surgical oncologist, meaning my specialty is treating breast cancer through surgery, any surgical need of the breast I will do. So there are a lot of patients who don't have breast cancer, but may have the BRCA gene, which is a gene that makes them at increased risk of developing breast cancer. Some of those women make the choice to remove their breasts before developing breast cancer. So I will do what we call risk-reducing mastectomies. And then there are some women that just have masses of the breast that are benign, but do need to come out. So I will do those as well.
Do you often enlist the help of a plastic surgeon when you do these type of non-breast cancer surgeries?
I do. And so that's a patient-dependent decision. Each woman feels very differently about what she needs for her body. So for some women, when we remove their breasts, that's a huge part of their womanhood. They identify themselves as women and the importance of womanhood with their breasts. So to lose their breasts can be quite devastating. And so we pair with plastic and reconstructive surgeons here at DHR Health to help reconstruct those women's breasts to restore what they feel is themselves as a whole. Other women, they are very comfortable staying flat and they don't want reconstruction. So it's really important to talk with each woman, let them know they have the option, and let them choose for themselves. But if they do, I would say it's 50-50, honestly. I think half of my patients choose to stay flat and the other half choose to get reconstruction. So it's really beautiful that we have here within our health system an opportunity to partner with our plastic surgeons to reconstruct.
And in terms of breast cancer screening, how often should a woman get a mammogram?
That's a great question. And it's controversial, I wouldn't say is the right term, but it's varied. So what happens is there are a multitude of different societies that are gathering data and using that to make best recommendations. So sometimes as different societies gather their data, they come to different conclusions. I follow the American Society of Breast Surgeons. And so that recommendation says women should get mammograms every year starting at 40, with a very important caveat, if they are average risk, right? But we have the US Preventative Task Force, and we have the American College of Surgeons, and we have ACOG, and everyone, some people might say, okay, you can start at 40, but you should do it every 2 years. Or some people say start at 50. The best way to guide yourself through a conversation with your physician is to talk to them about family history, any high-risk features you have, and then from there we can figure out when is the best time to start screening.
And what factors puts a woman at high risk for developing breast cancer?
There are a few. So one of them is age. We know that 1 in 8 women will be diagnosed with breast cancer in their lifetime, but the average age of diagnosis is age 63 in the United States. So as you get older, we generally see the majority of breast cancers being diagnosed in postmenopausal women. So age is one. But also estrogen exposure over a lifetime. We know that sometimes estrogen exposure can increase breast cancer risk. So for women, the younger they start menarche, which is when they start their menstrual cycle. So the younger they start menarche and the later they start menopause, that increases the number of years that they were exposed to estrogen. So young menarche, late menopause is a risk factor. But there's also family history. So it's really important, I tell patients, to talk with their family members and really get a good understanding and idea of who's had cancers in the family, what kinds of cancers, and at what age. So family history really plays into that. And then, like we said, genetic mutation. So some women are born with a change in their DNA that automatically increases the risk of breast cancer. And so that's something that we don't control, and it's something that gets passed down to us through our parents. And so through a conversation with your physician, we can parse through all of these details and figure out, are you average risk or are you high risk? And if you're high risk, then our recommendation is we shouldn't start at 40. We need to start younger at a risk adjusted age. Some of our genetic mutation patients, the BRCA patients, they start screening at 25.
And the role that genetics plays in the development of breast cancer, we've identified scientifically certain genes, but by far we haven't identified every gene. So just because a woman is negative for BRCA1 or BRCA2 doesn't mean that they're not at risk.
That's right. So it's really important. When they first started finding these genes, it was 1995, 1996 when they found the BRCA. That was the very first gene that they found. Now in 2025, we have hundreds, thousands of genes we've identified. And I would imagine in the next 30 years, we'll find thousands more. But right now we know of 13 different genes that really do increase breast cancer risk. I'm sure that will expand over the next few years. So what I would encourage, a lot of times when women get genetic testing, they just are tested for BRCA1 and BRCA2. So if you've tested for BRCA1 and BRCA2 and you're negative, that's great. But it's really important to talk to your doctor about having an expanded breast cancer panel where we can at least test you for all the genes that we know of up to today.
And what are the surgical options for breast cancer treatment?
So I tell my patients I really just have one of two options when it comes to breast cancer treatment. I'm either doing a total mastectomy where we are removing the full breast, or I'm doing a partial mastectomy, also known as a lumpectomy. And those are the really two options I have. And so how we come to that decision is based off of patient preference and size of cancer. So some women, they come to me and their cancer is so large that I can't offer them the small surgery. Unfortunately, I have to offer them the full mastectomy. But some women, if they have small surgeries, they do have the choice of preserving their breast. But they also have the choice of removing their full breast, even if the cancer is small enough that we wouldn't have to. So it's a very joint decision made between myself and the patient, explaining all the risks and benefits. And so sometimes their decisions are made because a surgical decision impacts another treatment down the line. So sometimes I'll have patients tell me, well, I really want a lumpectomy. And I say, that's a great option, right, if it is. And I say it's important to know, though, all women under the age of 70 who get lumpectomies automatically are going to get radiation. Just by making the choice to keep your breast, you are also now automatically receiving radiation. But there are women who, if they do full mastectomies, they can avoid radiation, right? So the surgical choice you make impacts a treatment down the line. And I think that's very important because a woman might say, well, I did think I wanted to preserve my breast, but I really do not want radiation. So if you're telling me I have to get radiation because I preserved my breast, I'd rather get a mastectomy. And so it's really important that you have a doctor, a surgeon who can communicate the pros, the cons, what your surgical decision now means for decisions later. And so we make this collaborative, informed decision so that the patient can make sure that they're making the best decision, not for them today, but for their future selves.
And do you collaborate with other specialties, both surgical and non-surgical, in the treatment of your breast cancer?
I do. So breast cancer is a very multidisciplinary field of study now. It used to be back, in the old days. And when I say the old days, in 1894, that's the first time we introduced surgical management of breast cancer. It was just surgery. There was no chemotherapy. There was no radiation. And women removed their full breast and all of their lymph nodes. It was a very morbid procedure. And when we say morbid, it means it came with a lot of complications, a lot of pain for patients. As we've gotten better at treating breast cancer, we've been able to use additional treatments like chemotherapy. So sometimes chemotherapy, some women, their cancer is very large and they really don't want to lose their breast. Well, then we can send them to have chemotherapy and use the chemotherapy to shrink the cancer down before surgery so that we can get them to a point where we can preserve their breast. So really having this collaborative conversation and team effort between all different treatment service lines is really important for making sure the patient gets the best care.
And what surgical advances have you implemented here at DHR Health concerning breast?
Yes. So recent advances is sensation-preserving mastectomies. So to kind of talk about that, we need to step back. So when we do mastectomies, we are removing the full breast. And women, when they choose to get reconstruction, we can reconstruct. But when we remove that breast tissue, all the nerves that give sensation to the skin of the breast are also removed with the breast tissue. And so while cosmetically, a breast may look, after a double mastectomy, a breast that's been reconstructed may look aesthetically very much like a normal breast. It doesn't feel like a normal breast. And it's very hard for women to kind of incorporate that part of their body back into their feeling and their sensation because it just doesn't, they're numb. And so it's a very hard thing for women. At the time of surgery, I am identifying the lateral intercostal sensory nerves. And I'm preserving them when I do the mastectomy. Before, we would just remove them. So now I'm identifying them, dissecting them out, preserving lots of length, and leaving them there. So when Dr. De La Garza comes in, he can either directly connect them to the skin to reinnervate the skin of the breast, or if the nerve is not long enough, we use a nerve allograft that we can graft in and reconnect to the skin. And so women months later are starting to feel sensation and they feel their skin again. And so this is just another way of restoring a whole sense of self to women through surgery.
What is the Breast Cancer Center of Excellence, and why is that important for a woman when they're deciding about cancer treatment?
This is an accreditation. It is a designation identifying a location, a hospital or a center, as a center that meets the highest standards of breast cancer care. So the American College of Surgeons is the overlying national body that has a committee called the National Accreditation Committee. And so what they do is they are tasked with identifying the centers throughout the United States that are providing the highest quality of care. So if you think as an institution that you are providing that care, you have to fill out an application. You have to submit data on everything you do across all specialties. And so it's very hard to meet all of these standards. But if you think you meet them, you reach out to them and you say, hey, will you come and evaluate us? Here's all of our data. They will send site reviewers down for a multiple day visit. And then if they find that you meet this criteria, the highest level of care, they bestow upon you an accreditation as a breast center of excellence. So this is important because, first of all, we're the only breast center of excellence south of San Antonio for the entire region. So that's a really valuable process that we have in place for our patients.
And finally, what advice would you give to women about being proactive concerning their breast health?
So I always tell women that it's important to know your body. And this is true for everybody, right? Every patient, man or woman, know your body, understand what's new, what's different. So I tell women starting at 18, you should start to do monthly breast exams. So once a month, you can make it the same time every month. Just do a physical exam. Feel your breasts, get to know what's your normal, so that if ever in the future, 6 months after you start feeling, you feel a new mass and you can say, well, I felt my breasts every single month. I've never felt this before. You need to see a doctor about that. You need to know what the changes or the symptoms would be. So if a woman sees or feels a new mass, or if her nipples are inverted, but there are a lot of women that have just naturally inverted nipples, right? So if your nipples have always been inverted, that's fine. But if your nipple was everted and now it's inverted, that's a change. We need to know about it. Bloody nipple discharge, changes to the skin, swelling. Those are signs that there could be something going on in your breast that needs medical attention. So pay attention to your breasts. Visit your physician and discuss these and make sure that they are ordering imaging, right? You can't. Patients and physicians alike, my hands are not any more special than a patient's hands. I cannot tell if something is cancer just by feeling. All I can do is feel a lump. We really need imaging studies to look through the skin and understand, what does this look like? And so I would say, know your body and talk to your physician the moment you see any change.
Thank you, Dr. Chapa, for sharing with us your expertise in breast cancer awareness.
My pleasure.
For our listeners who want to schedule an appointment with our DHR Health Surgery Institute, you can call 956-362-8170. Thank you for joining us on this informative DHR Health Talks episode. Don't forget to follow and subscribe to this podcast and share this episode with someone you think would benefit from this conversation. Stay well, stay informed, and remember, we are DHR Health. For you, for life.